Okay, Dr. McLaughlin, that was just a terrific presentation. I cannot think of a more meaningful presentation that we've ever had because it just uncovered some of these concerns. I mean, I've been around the prostate cancer world now for like 6 years, and I've gone to multidisciplinary clinics. I've been to a tumor board at NIH. I've talked to I don't know how many doctors, and not a one of them explained to me in this level of detail how these anatomical differences can influence our decision process. Maybe those guys looked at my MRI images and made, talked about it in their own heads or to each other, but nobody explained it to me. And when I had to make a decision to go with surgery or radiation, they didn't bother to explain this stuff to me. So I think this was an incredibly informative presentation, really opened my eyes, and I hope it helped everybody else who's been listening in. So thank you very much for that.
Well,
I think there are a couple of questions that come to mind, and let me just kind of break the ice here, and I'll ask my couple, and maybe the rest of the crew will want to join in. One thing that some people have been asking me, what do you do first? External beam, when you do combination treatment, external beam first or brachy first, and why?
yeah, that's a great question. For many years, I did this. The standard, I'd have to say, the standard of care is beam first and then an implant after. And then in parallel with that, there is a long history. There's a guy in Atlanta, and Chris, who, going all the way back to the 80s, has always done implant first with beam overlaid on it. Doesn't change the beam, he just gives the beam no matter what the implant is. And there is a magical synergy, you might say, to giving beam with the seeds going. It's almost like the seeds, you could say, are weakening the cells, and then you hit them with that hammer bolt of the beam. But it really, in reality, there's never been 1 ounce of evidence that one way is better than the other. Believe it or not, because our OR is shut down, I shifted back during COVID to doing beam first. And there are really some interesting advantages to beam first, because by the time you give the radiation, go do the implant 4 weeks later, the prostate is kind of frozen in place. Some of that mobility that drives us crazy goes away. So I'm an eternal student. You will never get a black and white answer out of me. There is just tremendous advantages to doing the seeds. The advantage of seeds first is seeds are the wild card, though, in the equation. Right? Beam could be given by almost anyone really well. If they do an MRI and don't overtreat the prostate, then it's not a worry. But the seeds are always a bit of a wild card for the reasons I said. The prostate squirms out of the way, the seed squirm. It's never the way we drew it up on the chalkboard exactly. And so I love the idea of doing the seeds, seeing what you got very accurately. And then what we do is not just the beam after the implant. We actually calculate the dose, every corner of the plan from that implant, and include that in the beam calculation. So the beam sees what you already got from the seed, just fills in where needed. So that is about as elegant an integration as you could have. Most of the patients on my vessel sparing study were done implant first, but as elegant as that is, and I could make up all kinds of theoretical reasons that might be better, I have to say, if I look at my results, sexual function, function, any of the critical outcomes I care about, they both are very effective, and the real determinant of how you'll do with seeds plus beam is not whether you do the seeds first or seeds second, but how well you do the seeds. If you do a good implant, it almost doesn't matter, because this implant, remember, is that high dose you can never get with feed. The implant gets you, those seeds are sitting in the tumor. So you're ending up with within the prostate. And now if you say, okay, all the tumors on the one side there, I can overload that side. And so the seeds are doing probably 3/4 of the work. Right? They're giving an enormous dose where you want it. Feed is just, I don't want to say window dressing, but it's just giving you the wrap around prostate, and you're covering the glands when need be and lymph nodes when need be. It's a wide shotgun aspect of the treatment, but the killer blow in the treatment, without any question, is the seeds, and if that's done well, it's really a tough call. I hope I answered your question. I don't think I answered your question, but quality of the implant drives the ship more than seeds.
Okay, well, I think you did actually answer my question. You said it didn't really matter because of what you said,
Right.
and that's fine. Because I've noticed that some oncologists do it one way, and some oncologists do it the other way, and there doesn't seem to be, a set way to do it. Okay, well, here's my second question, a little more complicated. I did read the study that you sent over with the material, which was where you were trying to address what I thought was a very interesting point. Okay, you made a point in the study that uh, the uh, the evidence, the accumulated evidence from, I think, from your experience and also the experience of other radiation oncologists, is if there is a good implant, um, there is very little chance of recurrence, and this is evidence for, there's two theories. One theory is that if there is a recurrence, it's because there was already some metastasis outside the prostate, and the other theory is that there was not good local control. And what this study is saying, and I've also read it from others like Dr. Merrick, he agrees with you that it's in almost every case a recurrence is because of poor local control. And I I was wondering if you could talk a little bit more about that, because in spite of all this, even in the best of even like Dr. Merrick publishes all his results, and he's been publishing 15-year results and many studies, and even the high risk guys that he's had done combination treatment, even in the best of case, there's still like a 15-20% chance of recurrence at 10 years. And that's, with the very best.
Yeah, that's high for Merrick. I think if you looked at Merrick, I think you're high for him. He's kind of in the 90% range, even with.
I know, but I think he cooks the books a little bit, because if you look at his data, what he categorizes by risk, I think he uses the D'Amico criteria, and he says, okay, so high risk. But if you look at the data that he presents, the high risk it can be, either Gleason of 8 or above, or a combination of 2 or more of the other risk factors. So, but when you look at his median Gleason score, it's below 8. So I figure I take his data with a little bit of a grain of salt. But
yeah, I've done some papers though with him. He is not a book cooker at all. He's kind of brutal.
okay, well,
so much so that years ago when he presented all this toxicity data, people had said, "Please, Greg, stop publishing this. You're making us look bad." He is honest.
really.
He's honest to a fault, but his numbers, what he's trying to answer are in some of those papers, not cooking the books. Different question. So he has a paper, which I think is very important. There's high risk. So someone has Gleason 8, their PSA is under 50, right? But they're Gleason 8. They're not 9 or 10, which everyone agrees is just prostate cancer, very difficult, even called lethal prostate cancer. Nonetheless, Gleason 8, PSA under 50, so they don't have a real high burden of disease. They're considered high risk. And what he's done is looked at whether someone like that needs hormones. And we're just in the process of trying to understand which, if you do combination, if you do seeds plus beam as he does it with wide margin, um, you don't, there's no advantage to hormone. Believe me, that's a huge number of high risk patients that some doctors that are a little bit too free with hormones, uh, they are, they're going to throw hormones at them, not even think about it, not even ask them, not even, sort of pass go, you need hormones. So I think what he's trying to do is always trying to look at who really needs hormones, who really needs combination. I think because of the way he does implants, very wide margin, uh, gets these good results. I think the weakness of Merrick's work is that I think he gets toxicity from those wide margins, and I think he discloses it, uh, but I don't think it's necessary. Uh,
Okay. Um, but if I may just go back to the question, because I think it's important for us, for patients, is okay. So, all right, we can argue about the exact number, but they say a small but significant number of patients do have recurrence, and um, and I guess in my mind the question is it really because of poor implant, or is it perhaps other factors like genetics? Maybe some of these patients have, a greater mutational burden, like maybe they have P10 loss or P53 loss, and
yeah.
which makes them, less radiosensitive. And has anybody, yeah, so how, has anybody studied that?
No, they haven't. It's interesting. Last year at our main brachytherapy conference, we had and I don't want to butcher his name, but he is a guru. They brought him in just for this reason. He does all this genetics testing, usually for the lower end of the scale to see if someone needs treatment or they can watch, and how do you chop up tumors and how does that help you decide treatment. It's very interesting. But what he said was also very interesting. He said, I have to tell you, if you do brachytherapy, none of the genetic stuff matters because therapy killed it. That was almost his conclusion. So the reality is, where I differ, another big difference between Eric and I is how you check an implant after. He does CAT scan. I do MRI plus CAT scan because I don't think you can see the prostate clear. Now he does wide margin, and so if he covers the CAT scan prostate falls, he's probably getting good implants. But I do think that if you do a good implant and you prove it with MRI, you do an MRI to find the prostate, see the prostate clearly after seeds. You can't see the seeds. The CAT scan, you can see the seeds, you can't see the prostate. Meld those together, which has been half of my life, an enormous amount of work, you can know with absolute certainty whether you covered the whole gland. And if you covered the whole gland with seed plus beam and got your dose, the chance of coming back and less than 2%. It's vanishingly low to come back after or implant. I agree if there's a weakness in your implant and you find out it repairs and then you look, oh yeah, that was cold. That was cold there. It wasn't covered as well. But you can tell ahead of time with MRI and CT, you can check it. And, this is a difference of opinion with Greg and I. He thinks he knows. Do MRI dosimetry is just an enormous amount of time. Um, it's just, he believes it's sort of the squeeze the juice ratio, as some people would put it. What you get out of all that extra work is certainly elegant, is certainly a standard that you can say with a straight face, this guy is covered and nailed and done. But it can be so much work to do that. It becomes a research thing. We're geared up here to do this. We've got very efficient at doing it. I cannot imagine not doing all the crazy things I do um, to check out a prostate implant. But I can certainly understand for someone like Merrick, whose very style is wide, that he's getting good implants. He's checking them by CT. And it's a less nuanced approach, but I think it would work for him. Whereas for most people, I would say you cannot possibly do CT because what the temptation that everyone's had forever with seed implant is you just circle the seeds, right? See the seeds, you can't see the prostate, circle the seeds, voila. Dose is good wherever there's seeds. Got a beautiful number you can put on a page and say, we covered this. But circling the seeds is a great temptation. Whereas Merrick, I don't think he'd ever do that. I think he wouldn't have to because his seeds, he could circle the seeds, but his seeds, I've seen his implants, seeds cover the whole thing. Very, very aggressive. I hope that answered your question. I do think genetics have a role in early disease. Decide if you're on that threshold between watch and wait and you have some impressive features that can tip you to treatment. But I think if you do, the reality is I agree with the kind of expert in this realm of genetics said, you know, all of these studies we have on failed radiation are based on beam radiation. Failure rate is very, very high if you wait long enough. But combination, well done. The failure rate within the prostate is less than 50%. And genetics wouldn't predict that. That's what his point was. It's just it works for anything. And, so I think, but I'm intrigued by your question. I think it's a great question. I have no doubt that someday we're going to be able to, you know, just think about what I said about 10% of patients not even making PSA. Their tumors are so undifferentiated, and these are often at least in 9s and 10s. They're so abnormal. They're so far from a normal prostate cell. Don't even make PSA. Now, I think you take such a patient, look at their genes, and find all kinds of bad things wrong with them. But they are not going to fail because of disease. They're going to fail. They have Mets when you treat it. Show up.
Right. So you do. There is a certain proportion of men who certainly do have Mets. That's what you're saying?
Yeah. But I'm intrigued by your question. I think it's a great question. It's just, I think it comes down to the quality, proving the quality of the implant that'll really
Fair enough. Okay.
get you pretty close. Yeah.
Okay, great. It's 8:40. I'm going to turn it over to Mike Scanlon. He raised his hand. He has a question. Do we still have time for a few more, Dr. McLaughlin?
Oh, yeah. I'm completely open. I'm fine.
Okay, great. Okay. Mike, why don't you go ahead? Unmute yourself. There you
go. Okay, can you hear me?
Yes.
Okay. Well, I was just wondering, I was 10 years ago, I had a Gleason 12, and I had there was a node that I had a DRE, and there's a node on my prostate, but I did. By the way, this was the best thing I've heard that you just gave us. The best I've ever heard. I really appreciate it. It's wonderful. But anyway, I chose to get surgery because I didn't know. I was afraid that I'd get radiation, and later on, which it probably would have come up as a failure, that it was out there somewhere. I wouldn't know if it was still in the prostate, or what do I do then? Because I kept hearing that if you get radiation, that they cannot do surgery then after that. So where do we look for this? There weren't any scans back then. So right now, I just heard that if you have any kind of node on there, you're probably going to have a recurrence, which I did, and no use getting surgery. But I got surgery, and it never got lower than 0.04, and to me that was not totally undetectable. So it was out there somewhere, and I was not sorry I made that decision, because even if you get radiation at this point, when I had my choices, how it's still out there someplace. The radiation wouldn't have gotten where it was out there, wherever it was. Is that true or not?
No, I wouldn't say it's true, but it does. It is one of the. I have to say that giving radiation after surgery because of a PSA tells you there's cancer somewhere in your body, and we know from our studies that the overwhelming chance for someone like you who had a nodule and that there are cells in the surgical bed, that they're in and around where the prostate used to be. Now, what the surgical bed is, for me,
Yes,
very
well,
different. But
I did.
yeah, if we
Excuse me.
treat it
I did get radiation to the surgical bed after that,
right,
and it did nothing.
right. And so what we would do these days would be get an MRI, see if we can see it. You might get a PET scan now, and the PET scan might have told you where it is. Might have told you it's in a lymph node somewhere. It may, but it sounds like you were treated when that blood test was very, very low. And it's true, we can't know. That has about a 60% success rate. So there was a chance you would have been cured with that. Um, if it didn't affect it, then it means it's somewhere else beyond it. But it's a rational blind treatment to give radiation to the surgery head because it often works. There are people that, and there's actual survival advantage doing that immediately. So I think it does work. It just doesn't work 100% of the time. Now we would have other scans that we would hope would define, that would help us define the effects.
Yeah, that's good. Well, I did have my PSA eventually went up to 12, and I had a PSMA scans at NIH and Johns Hopkins, and both saw the same thing, but they radiated the hell out of it at Johns Hopkins, but it never changed anything. And I went to Mayo, and they got their own scan up there, and they came back and said, you are widely metastatic. So the PSMA test doesn't work for everybody. Although there are identical results from NIH and Johns Hopkins, it didn't give the whole story.
Yeah, it is. And these new PET scans, and I sympathize with you because you kind of went the whole way to define it with the technology at the time. It is vexing and maddening.
Yes, but I was sent from Mayo home to get a chemotherapy and ADT, and that worked very well. I'm now, my PSA is less than 0.006. So
that's fantastic.
I had a good response.
Yeah, well, we've never had good chemo until the last few years for prostate, and it's amazing. I've been just thrilled with the effects on advanced disease, chemo, and these second-generation hormone therapies. It's very much the same as what I was saying for cardiac disease. If you have prostate cancer in this day and age, there's backups. It's like, it used to be if you had metastatic disease, it would be 5 years, and now you can almost punch the clock. Now I'm just seeing people 10 years, 15 years after, and it's really remarkable. But you have to find the right blend, and you have to be in good enough shape to take that chemotherapy. That's tough chemotherapy, for sure. So.
Yeah, it wasn't too bad except for the chemo brain, which I think I'm going to keep forever.
Yeah.
Oh, well.
Or ADT brain. Be careful what you pin the tail
That's
on.
right. That's right. It's a combination. But it was the combination that's lately getting the chemo and the ADT at the same time, which seems to have a high success rate.
Yeah, worked great. And I think Chip had a chat question I saw come through, but I didn't see the question.
Okay.
Well, no, I didn't. I raised my hand, and I've had problems before with people hearing me. Can you understand me right now?
Mostly. You trail off there, but yeah, mostly I can hear you. Yeah.
Okay. Well, the question Ethan brought up about the order of external beam and the brachytherapy. And I thought in the paper that you forwarded to us that it said it would be better to do the brachytherapy first, followed by external beam, because then you can fine-tune the summation of the two. But it seems that you're saying to Ethan, it doesn't really make any difference which order you do them in.
Well, I think there's advantages, and I do think that for some people, here's my point for that is, let's say you're doing implants. This came up. I had a colleague, and she, former resident, who had a implant go south and just wasn't very good at the quality of it. And she's very good, but she said, "What do I do?" And so we went through her options. She sent us the case. We worked out beam. So my point is, if the better you are at seed implants, the less the sequence matters. But let's just say you're okay at seed, pretty good. I don't mean to be, that sounds terrible to say that, but there are some people that are really good at it and that they're not the greatest in the world at it. Well, for someone like that, if you feel like your results are good but not perfect every time, then doing the seeds first and correcting the seed has tremendous advantages. And I was in that paper saying, kind of pitching the idea of seeds first just because it's not a popular approach. And I think it's a very great and elegant approach. But I would never quite come out and say, even in that, I would say the advantages are X, Y, and Z. But I would not say, I'm not losing any sleep if I go the other way. And again, I'm just rediscovering that there are even advantages to that. But it's true, in the paper, I kind of say this is a very, very attractive way to go. And I'm very happy with it. That's what I've been doing for 15 years. So I'm very happy with it. But I can, unfortunately, I'm cursed with, I can always see the weakness of anything and the strength of anything. And in the end, it's all quality. And if you really, if you're really honest, it has more to do with the striving for excellence at whatever you're doing, more than the treatment itself. I don't know if that makes sense. The people I know, and they're not all academicians, but they really are constantly refining their game, and they do well. And for them, I think the sequence may not be as critical. But again, I've done the implant first, loved it for many years. So.
Okay, thank you.
Couple more questions, though. I guess a couple more people raised their hands.
Oh, hi, this is Preston. I was wondering, it seems to me from reading your paper and from your talk that the skill of the brachytherapist is critical to success. And what I need to know is, how do I, if I'm talking to a doctor, how do I know that they're one of the good ones and not one of the less good ones?
Yeah, it's hard. It is hard because I can tell you, and I'll be honest. In the state I'm in, Michigan, we have a group. I would say my first advice would be, well, if they've published and they've published their results and their results are good, that's probably the easiest way to tell. But it's not that simple. You know, I know some brachytherapists in the state. I went up and observed the practice of this one group, and I was completely blown away. I learned as much on that trip as I've learned in any conference or anything. So it all has to do with the individual. It has to do with the numbers. I don't have a good way. There was an effort a few years ago to sort of try to define an elite level of practice that would have to prove with their cases. But I would say one thing that I would watch out for, I would want to know if they did MRI-based post-implant dosimetry. If they're doing high dose rate, that's not as critical. There isn't post-implant dosimetry, but in that sense, I think you can. How are they doing their quality assurance? Ask them. If they're not really doing anything non-CAT scan, they're doing CT. That would be a little bit of a red flag for me. So I think there are kind of clues, but it's really a lot of times patients trust their guts, and I think they're right. They kind of can tell.
Cross their guts.
So what would be the red flag for you? I didn't.
Well, if they're doing seeds, and when they check the seeds, they don't do an MRI.
Okay.
They get the dosimetry. That to me, I don't think unless you're doing what Merrick does, which is very wide implant, where you're not trying to nuance approach. But if you're trying to do a controlled dose, you have to do an MRI to make sure the seeds got all over the place.
Oh, okay. Thank you.
Okay.
Can I go next?
Sure.
This is Albert left. First of all, I appreciate your presentation. It was just absolutely outstanding, even though I scratched my head occasionally. So, but I'm kind of in the same boat with Mike Scanlon. Metastatic prostate cancer diagnosed last year, treated with ADT and chemotherapy versus radiation therapy based upon the volume of the lesions that I had. It was close, but my oncologist decided that chemotherapy was the better option. The question I have now is that I'm part of a clinical trial to evaluate the possible advantages of either prostate removal or radiation therapy subsequent to chemotherapy for prostate cancer. I was hoping to get in and be part of the randomized group that received the radiation. Unfortunately, I'm in the control group. So I did speak to the radiation oncologist in this area before going into the clinical trial. And he looked at all of my records and my tests and said that even outside of the clinical trial, he probably would be willing to treat me. So right now, though, there's a question. I've gone to my oncologist. I've gone back to the radiation oncologist, and I'm kind of put it in their laps as to whether or not this is something that I want to pursue. Some of the reading I've done seem to indicate that there are some significant or possible significant advantages, but I just wanted to get your take on it.
Now, when you say metastatic disease, what kind of metastatic disease did you have?
It spread to the bones.
Stage 4.
Yeah, stage 4.
Was it limited in scope, like a few spots, what they call oligo?
Well, it was 3 or 4.
Yeah, that's oligo. That's few, and that's
okay.
Limited. Yeah, that's a special category. I have to say, I'm a little more of an advocate for radiation in that setting as an advantage, because I do think trying to get a really long-term suppression, that there are men that go an awful long time by radiating few mets. So it's sort of like you're treating all the spots you know about. Yes, there are other ones out there that'll show up at some point, but it's a very interesting character to look at it, because the other piece of it is you treat the prostate, and we know that for men with prostate cancer that there's some showering from the primary source. It's kind of ongoing. And hormones do it, but the hormones do not sort of knock that out in the way radiation would. So my own bias is, if I were you, it's always dangerous to say, but if I were you, I would probably tilt towards radiation. But I would also say, with the modern era PSA, you can say, hey, my PSA has gone up, do it now. I don't think you'll lose that much. You could say, I'm going to stay on the conservative group, because you may go several months or even years without needing a change. But are you on hormones now?
Yes.
Okay.
I'm on it, yeah.
Eligard.
Lupron, Eligard, yeah.
Yeah. So
and
that's
I have very few side effects, so.
Yeah, you're very lucky there. But I would say there's kind of a, this is a sort of a complicated philosophical thing, but there's a way that I try to solve these dilemmas. So in an apparently hopeless situation, treat the most positive scenario you can think of. So, what did that be? Your situation, well, it's an apparently hopeless situation. You have metastasis, but treat the most positive scenario. The positive scenario is you have limited metastasis. If you blast those that can come, how much more do you have? Who knows? So in a way, you're treating the most positive scenario, but it's not an irrational groping in the dark saying, okay, I know where I have it, the major deposits. I'm going to take those out and see how I do. And I think that would be, in my mind, treating the most positive scenario. But with PSA, you don't have to make this an either or thing. You could just say, I'm going to have a very low threshold. If that PSA goes up 1 point,
Okay.
just, you still might have period.
Yeah.
Now, the advantage of doing radiation to me in your situation would be to try to get off ADT for a period. But you don't mind it.
That's,
You're not
yeah.
a guy who's absolutely miserable like the guy I talked about in this story. And so in a way, it's very complicated when you're doing well with a treatment, but that's success. I would just watch the PSA and have a low threshold for going radiation.
Okay. Sounds good. See if there are any more questions.
Let me just interject at this moment. So I noticed there are some names here that I'm not that familiar with. These are some guys who are not from our group. First of all, I want to thank you for joining today. And is there any questions from any of you guys? Anybody who wants to add another question at this point? If not, I have at least one more. Okay, so I'm going to jump in again. So Dr. McLaughlin, I think we all are very appreciative of your approach to try to minimize toxicity, maximize quality of life while preserving oncological control. And you and others have claimed that really, if you do combination treatment and you have a good implant, really you don't need ADT. Well, I listened to that video, that YouTube video, several months ago, and then after that, I had a chance to talk with my radiation oncologist, who is, he's a straight shooter, straight NCCN guideline kind of guy, which is what his institution requires. Okay. And he says, well, and I tell him, well, why should I get so much ADT? Because he wants me on it for 18 months. And I know that the trend has been to reduce ADT use, not just by you, other people as well. Dr. Dattoli down in Sarasota has really not cut back a lot on ADT. But anyway, so I tell him, well, I said, well, and I showed him the slide, because I took a screen capture of the slide that you presented from the radar trial in Australia, which showed that, okay, if you really need ADT if you're just going to do external beam, and it's very efficacious. 18 months is really what you need if you're just doing the straight, your run-of-the-mill dose of external beam. But the higher the more you escalate the dose, the less there's need for ADT. But if you do combination, according to you, there really isn't. You can really get away with very little ADT, if any. Okay. Well, he said. So, but then he comes back and says, "Well, I've read that radar trial results. I think the primary investigator was Dr. Denham, and he said that's not the way I read it. He says Denham says in its conclusion that with high risk prostate cancer, even with combination, there is a benefit to 18 months. So he shut the door on me. He said, look, He said, I want you to get 18 months. He wants me to get 24 months, but I'm kind of battling him to knock it back, and he kind of grudgingly said, okay, 18 months. And so, anyway, that's what he told me. And
Yeah, and I think the interesting thing is on the update of that trial, it does look like there's an advantage. Now that gets to the high dose rate versus low dose rate.
Right.
Because high dose rate, until the Ishan study last year, high dose rate did not have a good track record in high risk. And so what I don't know is, the $1 million question with that study is, does high dose rate brachytherapy need more hormone therapy because it's not as powerful in its own right? It would be interesting if seeds were on it, and I do think it's going to break that way. What I don't like getting too dogmatic about an advantage, though, and without saying, what is the, how big is the advantage? Not is there a statistic advantage? Because a lot of what I've done is, okay, this is the advantage. It's 12% at 10 years, 20% at 10 years. It's a 20% advantage. That means that for 80% of the patients in the study, there was no change. They're determined. They were not determined by the outcome. But the other piece is, it gets personal very quickly, because if you're even debating taking 18 months and okay with it, you're probably doing okay with the 18. So a lot of guys would say, they would say, I don't feel good. I never feel right. I have lousy days. And I'm trading something. So the other piece is, you can say there's an advantage. I want you to have it because I want you to have the best outcome and the best numbers. To me, I think you misinterpreted me when I said the advantage with hormones combinations not great. I showed you a couple cases where I was insistent that with disease outside the prostate, there's a huge, incredible advantage to hormone. And I suspect that the main advantage to hormone is in guys who have local disease and respond to that. So you look at the MRI, if you've got a big tumor sticking out the side of the gland, you need hormones to eat. Anyway. But if you then go the other route and say, well, in this study of 500 patients, there was an advantage. Here is the problem. Here is the $1 million problem that came up in a recent study. What if there are groups in that study that do lousy implants, and their lousy implants are rescued by hormones? But then on the other arm, they don't get hormones, and they do lousy implants. You don't know when you have a multi-institutional trial. You don't know if those hormones merely rescue bad techniques, the bad actors. And I'm not just imagining this. I showed you that study that was just published last year, where 15% of the patients on the study had lousy implants, 15% had poor implants, and that poisoned the study. So, but if they had hormones, if that study had hormones, I'm pretty sure hormones would have made a big difference. It would have fixed a lot of those. So the problem is really it's global. So I would say, Mike, I would not draw from the study the conclusion that you don't need hormones. The guy, at least 3 of the cases I did, I was a strong advocate for hormones. I would say the duration of hormones, I have some questions about, but I also say, well, look at the curve, look at the difference. Is that difference worth it to you? Is a 10% difference at 10 years, worth it to you? And if you're feeling lousy every day for 2 years and then you're going to take another year to recover, how do you weigh this? This becomes very personal at some point. And it sounds to me like, you'd like to get off of it, but I don't know. And this is where I am very, very dogmatic about stating the obvious, right? If you really think you're getting an advantage and you want to get every advantage, take hormones. The way I do this with patients that I see is say, look, well, the study looks like there's an advantage. Go ahead, take it. See how you feel at 6 months. See how you feel at 1 year. And then make the decision in those increments. Because there are some men who at 6 months, they're nothing, no problem at all. At a year, they say, I have had it. If you look at those big studies of hormone therapy, adjuvant hormone therapy, a full 30 to 40% of men quit. So they were supposed to get 2 years or 3 years. 40% of men quit on those things. They didn't get full length because it was just a cumulative effect. And so I think it is one of these tough things, one of the toughest things, because it's sort of like any conservative, edgy argument. Well, what? You want to die? What, you want to live? Whatever you can. You've got to do everything. It's the same argument that used to be given in the 80s, right? You got to live. You're going to lose your erections. You're going to be incontinent, but you're going to live. And I kind of hear a shadow of that argument with hormones. It's proven. You see, it's proven. There's a survival advantage. Well, the survival advantage is the survival advantage canceled out by a quality of life disadvantage. And do we even have any idea how to calculate that? Well, some men do, right? I have some men read about hormones and they say, I would rather die than this. Other men take it. I had 2 men tonight say, not that bad. And that's been my 20% thing. 20% of guys get ADP, there's no big deal. They're kidding with their wives about hot flashes. 20% is a pretty life-altering, crummy thing. You heard the case that of the wife as account of the man who wasn't complaining himself about anything. So it's very personal, very individual, but I wouldn't interpret my stance as, oh God, get rid of hormones. But weigh it, think about it, read about it, and see what are you getting? What is the actual survival?
Yeah, I understand that. That makes a lot of sense. I guess I'm more concerned. Personally, I have not suffered too terribly, but I'm more concerned about the irreversible long-term effects of 18 months of ADT. Dementia. I'm 72. Dementia, cardiovascular.
Yeah, no,
metabolic, and
yeah.
of course the osteoporosis. So
yeah, the data on 15-year, it's very interesting because Stock, one of the gurus, Stock and Stone, they have the best data. That's, I think, some of the scariest on late. So everyone's worried about early cardiovascular death, which I've seen 2 times in practice that I didn't even recognize years ago. But men who started hormone therapy and 2 months later sort of had this cardiac event, died, and it was just too big a coincidence. But Stock and Stone have looked at, they have these massive numbers, 600, 800 patients, and they do say that there's late cardiovascular risk from long. They did not see it with 6 months of hormones. So there is sort of a cumulative thing that you have to factor in. On the other hand, if you hit the gym, this is Eric's thing, if you hit the gym, sort of resist the obvious effects of hormones, kind of fight for the right to party. That's what I tell all my guys. You got to fight for the right to party at a certain age. If you're taking hormones, you're going to have to do something to counteract those effects. And you can actually counteract some of the effects. But I do think very personal. And I hope I wasn't too light or too glib on the hormone thing. I really, it's a much more nuanced question for me, tough question for me, than it might appear when I'm doing my sort of stand-up routine here to try to be interesting. It really is. It's a tough one.
Right, and I understand that, and I think we probably all recognize that. I did do HDR, and so maybe it's more important for me to, in fact, to do the 18 months. It's definitely tolerable. I think the biggest issue I'm having is sleep issues, hot flashes, but otherwise, muscle loss and gaining. I've gained 7 pounds, and I've read that 7 pounds is there's a crossover. More than 7 pounds, there's much more risk of metabolic syndrome.
Right.
And I'm trying to fight it as hard as I can, and I do hit the gym regularly. So
Yeah, yeah.
Okay.
Yeah,
Thank
but
you.
I do think the HDR, if I had to read between the lines without being too biased for LDR,
Right.
those single dose HDR studies are somewhat discouraging for the overall effectiveness of HDR. It would not surprise me if there was a greater benefit with HDR breaking than LDR. That's what kind of Merrick and I were kind of coming to, that we're trying to do a big study of long-term follow-up to see what hormones actually do. I think it will probably turn out that with LDR, there may be less of effect than with HDR. But I think knowing what I know about some of the effects of HDR, if you're tolerating it, you got a great doctor there. I know who your doctor was. Couldn't have gone to a better person for that, and I trust him. They know best on that. So.
Okay.
Another question.
Yeah, I'm curious. What I've been hearing about taking ADT, my situation is quite different. 3 years ago, I was diagnosed with prostate cancer. My PSA was 160 and rising. It actually got up to 200 about 2 weeks later. And after an MRI, CAT scan, biopsy, I had the Gleason score of 10. And when I saw my doctor, I figured, well, it was going to be chemotherapy or radiation or prostatectomy. And he said, no, we're just going to do ADT. And I said, why? And he said, well, because your quality of life is going to be miserable with any of those other possibilities. At your age, I'm 73, he said, we're going to use the ADT. It's been 3 years now, and I'm still riding the wave. My prostate my PSA is still undetectable, in an assay. And I said to him, well, what should we do? He says, just keep going until your PSA starts rising, and then we'll think about what we have to do. But when I hear you guys talking about 2 years or 18 months, am I in for some really bad consequences of taking ADT for 3 years or more? I'll be starting my 4th year next month.
No, I don't think so. I would be, again, if I apply my logic, right, in an apparently hopeless situation, treat the most hopeful scenario you can muster. The most hopeful scenario you can muster, even though your PSA was very high, that it was all local disease or local regional disease. I have 2 patients with PSA in that range that are 10 years out with no disease. And most people would say, you can't possibly have local regional disease. You have to have micrometastatic disease. You can't see it. I don't think that's true. I've talked to Michael Zalewski at Sloan Kettering. He also has a couple cases. So again, in a hopeless scenario, what is the most positive? In a hopeless situation, what's the most positive scenario? The most positive scenario is you've got a lot of local disease, and you should treat it very aggressively locally and hope it never comes back instead. I have 2 patients, what you described. I have 1 patient, a PSA of 180, massive growth all through the pelvis. This was 10 years ago. I treated him with seeds, beam, 3 years of hormones. He never recurred. I have another man who was 120 with lots of bad disease. And again, at the time, I'm sure you kind of heard this, no, you really have metastatic disease, we just can't see it. But positive, the real scenario that you should entertain is if you don't have metastatic disease. Part of the reason it responded so well is that it's still localized. You had a phenomenal response. Now you just sort of seize the day and treat very, very aggressively locally, kind of shut off the source. And believe it or not, what you described in my mind can still be curable. But
Well, I was just wondering if I should be thinking about radiation now, or if I can still wait until my PSA finally starts rising once I don't respond to ADT.
Yeah, I would
Then
definitely,
do
I
the
would
radiation,
definitely,
or should I start thinking about doing it right now? Though,
yeah,
I'm sorry, you would definitely what?
I would probably think about doing it now, but I would also be ready to pounce at the first sign that disease is coming back. Because again, it's a scenario thing, right? What do I think? We think we're so smart. Your number was so high. Everyone, I would have said 10 years ago to those guys, hey, this is a shot in the dark. I'm giving you the benefit of the doubt. I would not have expected them to hear that kind of number, but they are. And I've asked around, try to gather a study of 10 or 20 such cases that prove that you can't judge whether someone is hopeless or not from PSA. That if you treat them aggressively, there's a chance for cure. I would, if I were you, I'd be thinking that way. I'd be thinking, yeah, it looks bad, but we've had a great response to hormones for 2 years. I agree with you. We've already doubled what most people get out of it. And usually by 18 months, you start to see resistance. But you could go either way. It's just I would not mess around for a minute if it started up. I would go to get the radiation going right away.
Well, that's what my doctor was saying too. He says, we'll just keep going with this until we see that it no longer is working, and then we'll move on to the next step. So
Yeah.
he doesn't know, actually. When I first saw him, he estimated I had 3 years. But Zytiga just came onto the market at that time. He
Yeah.
didn't even know what it was when I brought it up to him. And then he got Medicare to pay for it. It was very expensive. And between the Zytiga and now the abiraterone and the Lupron, and I take an Exgeva shot, I seem to be just coasting along. And by the way, I want to echo what the others said. This is an amazing presentation you made, and I really appreciate the effort you put into this. And that this American Life testosterone episode, it turns out I had it on my phone, but I've never listened to it yet. So I will be listening to it after our meeting is over.
Well, great. Yeah. Well, I appreciate all the feedback. I was happy with the talk. It takes a long time to put these together, but I finally kind of was able to put together my practice. It's interesting. I've been doing these scheduled, see someone, wait 6 weeks. I've been doing that for 3 years, but I never quite put it together in the organized fashion that this kind of really forced me to do that, which is great. It's great to have. So.
I have one more technical question, Dr. McLaughlin. When you use MRI, so do you use it basically in real time? In other words, I'm sure you do MRI imaging before, you mentioned that, but then you insert the seeds and do you re-image later afterwards to make sure that they're in place, or?
Yeah, you have to do, to get the most accurate dosimetry, as we say, you wait 3 weeks or 4 weeks, and then you do a CAT scan, and at the same time, you send them over for an MRI. The MRI shows you very clearly where the prostate is.
Mm-hmm.
CAT scan and seed. So you do a fusion, an image fusion, and that gives you the answer. And that's, but again, some of those flaws that I talk about, the base, seeds never getting to the base, those would never have been discovered without an MRI. You would never have known that because you would just circle the seed on CAT scan. You'd never know that you missed it by an inch. All the seeds were shallow, and it was shocking when I started. Boy, I'll tell you, ignorance is bliss after all.
But so you say you do a second?
Oh yeah.
Okay.
You have to. Yeah, yeah, you really do. Or you can't see the prostate. You can see the seeds, but the temptation is you have these seeds, and then you have a big cloudy mess on the prostate, and circle the seeds. And say, okay, that's the implant. That's the prostate. But that whole thing may have been phase shifted a centimeter below the. It's not as deep as you think. you'd never know it without the MRI. So I think it's critical you do the check with both.
Hmm. Okay. But it's not commonly done, right? I mean, Dr. Merrick.
Yeah, Dr. Merrick, that's been a bone of contention. The minute I wrote that paper almost 15 years ago, he wrote an editorial, we don't need no MRI. It was kind of funny because we're colleagues. I really respect what he does, but man, he didn't budge on that. And I think for him, he could justify because of the way he does implants that the MRI is not critical. But for almost anyone else doing this, I have that resident showed me her case. It did not go well. She would never have known how bad it was without an MRI. At least she did that, and she does great. She does great work. But what I was saying, the dynamic anatomy challenge for some cases, you can be in the middle and, the bleeding starts, you can't see the prostate, you think, kind of keep going through your steps, you think it's okay, but unless you really, really respond to those dynamic changes, it's really,
Yeah.
really tough.
Okay, that's one of the aspects that never really crossed my mind, when I'm trying to understand. I tell you the truth, I decided to go with HDR because, for a number of reasons, but the first I heard about it was at a PCRI conference in LA a few years ago. Dr. Demanis from UCLA.
Oh yeah, he's great. Yeah.
He was promoting it, and he said one of the main reasons to do it is because you can really place the seeds very accurately, get a really good implant that way.
Right.
And so, that was, I thought, he said that was an advantage of HDR. So I don't know. What do I know, right? But again, all these technical concerns are something I had never really known about, and that was great that you presented that.
Yeah, to me, I've made a living completely on the technical end. I haven't done many big studies. I follow the big studies, but to me, the final determinant of what's going to happen is the quality of the treatment more than the treatment. So there is it's very
yeah, and actually the doctor I went to up at UCSF, apparently his specialty is he doesn't use a template. He inserts those catheters
freehand. Yeah.
Freehand.
Yeah. Well, it's kind of what I was saying. Remember, I have the bowler and I have the golfer guru, and they both have fantastic results. He's famous for that because whatever you do, that's what I say. As long as you have some kind of feedback loop, so I have a way of refining your excellence. So if you're getting closest.
Right.
Everyone that I know that's really, really good at what they do, they have set up some kind of brutal feedback that tells them that it work.
Yes.
So it's really a relentless. What do they say? The relentless pursuit of perfection.
That's right. And your comments that, and I've read it in other places, that it's becoming less and less popular to do seeds in spite of the fact that they give, tremendous, great outcomes. But fewer and fewer people are doing them. And like you say, it's extremely important to have experience.
Right.
And so I think it's a great shame. And hopefully it'll get reversed. Maybe if you guys keep beating the drum and the patients become, start to demand it more. Hopefully it'll stay alive and prosper.
Yeah, I think it will. I think it's going to go the other way. I think it's going to make a comeback. But I'm not a drum beater. I just like, I like the results to speak for themselves, and they really do. It's going to be very hard to see that disappear.
Okay.
Yeah.
All right. Well, I certainly feel it was great. I'm very lucky that we heard about you, and now that you've presented to us, I think it'll give our group a new perspective
Great. Well,
on this treatment.
oh, very, very glad to hear it. Very glad to be useful and really enjoyed it. Great questions.
Okay.